Good morning, good afternoon, and good evening, everyone. I would love to extend the warmest of welcomes to all of you joining us today for the first Global Learning Network event of 2026. My name is Emily Hedrick, and I have recently joined the 717 team at Resolve to Save Lives to support learning and capacity development for the 717 Alliance. And I am thrilled to support this discussion today, the first of many excellent learning opportunities we have planned for this year. Before we get started, there is just some housekeeping. We are happy to offer interpretation today, available in French and Spanish. So please join the relevant audio channel as needed. Let us know if you're having issues there. Automated captions are also available in your meeting controls at the bottom of your screen. And throughout the course of the event today, please add your questions to the Q&A box at the bottom of the screen, and we'll address some of your questions in the Q&A portion of the webinar after our researchers speak today. And anything we can't get to in person, we'll try to answer in writing. And so to open our discussion today, I'd like to introduce Dr. Mohamed Lamorde, Project Director of the 717 Alliance, to kick us off. Mohamed, over to you.
Thank you very much, Emily. And once again, a big welcome to everyone to this webinar. Our last webinar was fantastic. We had a presentation on epidemic-ready primary health care, and we saw how the evidence was demonstrating that capacity building at primary healthcare level could really help us meet the first 7 and the 1 of the target. Today, we're going to do something different. We're moving forward to look at the evidence base supporting the use of the 717 target. And we often hear that phrase, speed saves lives. But really, what are the studies and what are the findings for those studies that support us to use speed in the time of emergencies? Today, we have distinguished speakers that are going to be presenting to us. They're going to present recent evidence that have been published, and we're really honored and delighted to have them with us. I'll start off by giving a bit of background for first presentation. The first presentation is work that's been done in Uganda. And it's really an interesting story of collaboration and really study. A PhD student worked on putting together a data set, working with the Public Health Emergency Operations Center, the Ministry of Health in Uganda, as well as the Infectious Diseases Institute, and compiled a data set that has been made available for further research. And today I'm really pleased that our colleague Sooyoung Kim is able to highlight some of the findings of an analysis of that data set that relates to 717. Sooyoung is a advisor in the Epidemic Intelligence Unit at Resolve to Save Lives, and her work focuses on strengthening the use of data for decision-making, supporting countries to design and implement collaborative surveillance approaches, and also strengthen capacity for earlier detection, better preparedness, and more effective response. Sooyoung is an infectious disease epidemiologist with interdisciplinary training in health economics and decision science, and she holds a PhD in public health policy. Sooyoung, you're very welcome, and over to you for your presentation.
Thank you, Moha. Hi, everyone. This is Sooyoung, and I'm very happy to represent the group of researchers who worked on this study about timeliness of detection, notification, and response, and its impact on outbreak outcomes. If you go to the next slide, please. So our study really started from a simple question of, does timeliness matter? Can timely detection, notification, and response to an outbreak lead to a lower number of cases and less people dying and outbreak ending sooner? So what we did is we used the data set from Uganda that includes 84 One Health outbreaks that happened between 2017 and 2022. And what we did was to conduct a simple regression analysis between the timeliness indicators and the outbreak impact indicators, adjusting for disease categories that could work as a potential confounder. Next slide, please. So this is a very complicated looking busy table that depicts the regression outcome, but I will try to break this down into some of the key insights that we were able to extract. If you go to the next slide, the first finding that we had was a unit increase in the days between outbreak start and detection was associated with a higher number of cases. In a plain language, this means that outbreaks that took longer time to detect had more cases. Next, please. And we also found the unit increase in the days between outbreak start and detection was associated with a higher number of deaths. And in a plain language, this means the outbreaks that took longer time to detect also had more death. Unit increase in the days between outbreak start and detection was associated with a longer duration, which means outbreaks that took longer time to detect also took longer to finish. And next, please. Unit increase in days between event detection and notification was associated with fewer cases and fewer deaths, meaning outbreaks resulting in higher case numbers and death tend to be reported to health authorities more promptly. For us, this was kind of counterintuitive because we thought that if the outbreak gets notified faster, it will result in lower number of cases and lower number of deaths. If you click again, our hypothesis after having this finding was that maybe a heightened sense of urgency among health workers make the higher risk outbreak gets notified faster to the authorities. Next, please. Another counterintuitive finding that we had was that the time taken between outbreak notification and initial response was not significantly associated with any of the outcome variables. And we were wondering, shouldn't a faster response really improve outbreak outcomes? And our conclusion after the discussion was that this might not be what's happening in real life, and this is more of our study's limitation. If you click again, so these are the potential biases that could have masked the impact of this impact that could be observed in real life, but not in our studies. First, there was a limitation of how the response state was recorded in the data. There were a lot of missing data on response state, and the data set already was pretty small that could have reduced the power of the regression analysis that could have masked the impact otherwise would have been observed. So what does this study tell us in terms of storytelling? The first thing is that we think early detection really matters. Faster detection is associated with fewer cases, fewer deaths, and shorter duration of outbreaks. And this makes us believe that surveillance timeliness is an important determinant of outbreak impact. Systems respond faster to severe outbreaks, but maybe not necessarily to the emerging ones. The emerging new outbreaks does not give the same sense of urgency to the healthcare workers that hence does not trigger a faster notification. Measurement can really enable improvement. By tracking these states of detection, notification, and response milestones, countries can really see exactly where delays occur in their outbreak detection and response and target the necessary reforms accordingly. So from this, the key takeaway that we had from this study was, if you go to the next slide, please, 717 can really work as a performance improvement tool. Timeliness really directly affects health outcomes, and 717 offers a very straightforward, simple performance management framework that provides very clear measurable targets. And it allows teams to track where delays occur and identify bottlenecks and improve response speed in real time rather than after the fact. The bottom line is that we think what gets measured can get improved. And another takeaway that we had from this study is that we need more evidence. Our study was one of the first to demonstrate the positive public health impact of timely outbreak management across a large number of events. Um, and even though it was an imperfect study with a couple of limitations, I think the evidence that we generated some effective advocacy, and stronger evidence can lead to even more effective advocacy. Evidence-based advocacy supports systems change. It provides policymakers with a concrete proof that investments in surveillance and response timeliness can reduce outbreak size and severity, not just improve reporting. And quantifying health outcomes really opens the door to estimating averted disease burden and return on investment. And once we start talking about return on investment, it really resonates with the donors, which can create sustainable funding and political commitment. So if you want to learn more about our study with details, the paper is available, I think, online. Next slide, please. Oh yeah, the paper is available online, and thank you for your time to listen to my presentation. Happy to take any questions during or after this presentation. Thank you.
Thank you very much, Kim. A really remarkable study that I feel dovetails to our last global learning webinar. In our last global learning webinar, we were looking at methods or approaches to really improve detection and notification at facility level. So working with frontline healthcare workers, showing them case definitions, supporting them to learn about outbreaks and notification systems in country. And what we saw from that in that webinar was that most of the outbreaks were reported within the 7 target and the 1. Now, what your data is telling us today is that that is really where we have the biggest opportunity to have smaller outbreaks, to save lives, and really reduce burden. So first comment to you really is, how does it feel being first? And ever since you published, you had that comment, to our knowledge, we're the first to demonstrate this. Have you had feedback from other researchers that say, hey, there are other studies that have been published that are similar? What has been the reception of your work as a pioneer in this field?
Yeah, thanks, Moha. I think the biggest kind of feedback that we received was a lot of countries and public health officials approaching us, asking that they want to replicate the study using the similar methodology. And our study was really just a simple regression study. And there are many other methodologies that are way more rigorous to quantify the impact. I think the key limitation is that the data is often not sufficiently collected, so it requires a lot of additional effort to collect and triangulate data. But I think embedding this 717 data collection and early action review into the existing country's health and event tracking system really enables this swift real-time data collection, which can lead to a lot more publication of this type of advocacy study. So yeah, I haven't really seen any type of similar study that generates evidence like this, but I have to admit that I haven't been really actively looking for one. Will be happy to receive anything from any colleague so that I can also learn from other people.
Thanks very much, Kim. It's really been a joy to see this study published. And once again, colleagues, if you do know of other work or you have an interest to replicate this work, this is an opportunity to connect with the speakers and with the 717 Alliance so that we can build up on that evidence base. Nevertheless, really striking findings, Kim. We're going to be tracking to see if there are additional questions that come up in the chat, and we'll let you know. But thank you very much for your presentation. So we're going to move on to our second presentation today. And our second presentation focuses on vaccine preventable diseases and outbreaks really related to vaccine preventable diseases. We do know that vaccine preventable disease outbreaks have taken a turn, and there's a much more in the news right now around it. It's more of a topical issue. Unfortunately, outbreaks that we expected to have been controlled are starting to reappear. Countries are seeing new outbreaks of diseases like diphtheria, and then measles is appearing in places that once eliminated it. And so today we're going to have another presentation that looks at the impact of using a timeliness approach and being more timely in our detection and response on outbreak outcomes for vaccine preventable diseases. And we're honored to have our speaker today, Dominic Delport. Dominic he has a background in physics and applied mathematics. Dominic works for Burnet Institute, which is a strong collaborator of the 717 Alliance. His work with Burnet has focused mostly on maternal and child health work and nutrition and COVID-19 modeling. And he has experience using agent-based models for his work, such as CovaSim. He's developed models really to investigate the impact of vaccines and non-pharmaceutical interventions on outbreak outcomes. And he has also worked closely with Gavi, the Vaccine Alliance, to develop methods for modeling vaccine outbreak response programs. And so we're really thrilled to have Dominic join us today and present on his work, which was published actually just a few weeks ago. So first, Dominic, congratulations on your work and on the publication. Over to you for your presentation.
Thank you so much, Mohammed. So yeah, today I'll be just spending about 8 to 10 minutes talking about some of the primary results from a modeling analysis that was recently published, as Mohammed highlighted, where we looked at the impact of making progress towards the 717 targets for outbreaks of cholera, yellow fever, meningococcal meningitis, and measles in low and middle income countries. Next slide, please. Before I begin, I just want to acknowledge that a lot of this work was conducted on the lands of the Boonwurrung people of the Kulin Nations here in Victoria, and I want to pay my respects to their elders past, present, and emerging, and extend that respect to all First Nations people. Next slide, please. So I'm mostly going to be talking about the results of my analysis today, but I want to give just a little bit of background so that if there's anyone who's not particularly familiar with reactive vaccination campaigns or with mathematical modeling, that hopefully you'll have a grounding to understand what I've done. So we know that when outbreaks of vaccine preventable diseases occur, the best tool that we have is to vaccinate the population that's at risk. And there's a growing body of evidence that indicates that the faster we can get vaccines into the population and protect them, the greater the protective impact they will have. And this makes perfect logical sense. The problem arises where in low and middle income country settings, where outbreaks are most likely to happen because they have weaker surveillance systems and weaker health systems, it can often take a very long time for vaccines to be provided to the population. And this is despite the fact that vaccine stockpiles exist around the world whose entire purpose is to be accessed in the event of these outbreaks. And as we all know, the 717 targets are metrics for assessing outbreak readiness and timeliness. They assess and try to motivate us to respond as quickly as possible to outbreaks. And so I wanted to do a mathematical modeling analysis to try and understand how much more good could be done if we were achieving 717 specifically through the lens of reactive vaccination for vaccine preventable diseases. And I want to be clear, I'm not proposing how to achieve the 717 targets. I'm merely generating some evidence to try and motivate everyone to invest more and investigate more so that we can all try and make progress towards achieving 717 together. Next slide, please. So mathematical modeling. It can be a bit of a complex target and a complex concept. So I'm just going to briefly describe that I have built a series of models that are able to simulate and represent how disease transmission occurs amongst human populations. And I've done this for models of cholera, measles, yellow fever, and meningococcal meningitis. I built these models and I made sure that they were fit and could reproduce outbreaks from more than 200 outbreaks from low and middle income countries that have occurred over the last 10 to 20 years. And then once I was confident that my models could reproduce outbreaks that have actually happened, I wanted to simulate a series of scenarios investigating what happens if vaccine responses can meet 717 or make progress towards 717. So first, I tested different scenarios. I have a baseline in which the response characteristics, so that the response time once an outbreak occurs, are basically matched to the average response time from historical outbreaks in my dataset. And what this means is that once an outbreak begins, it takes about 3 to 4 months for vaccines to actually start to be delivered to the population at risk. Once I had that, I then started to investigate, okay, what happens if we're responding faster? And I did this in 15-day increments down to a scenario which has a 15-day response time representing achieving the 717 targets. This figure in the bottom right is just a very simple schematic representation of what's happening in the model as we initiate these vaccine responses faster. So for example, we can see a red curve, which is a relatively large and long-lasting outbreak where a response happens quite late. This is representative of this average slow response time. In yellow, we see a second curve where perhaps we're responding more quickly before the peak of the outbreak happens. And if we can do this, it reduces the peak and reduces the duration of the outbreak. And then further along to the left is a blue curve where perhaps we've responded within 15 days, achieved 717, and even further reduced both the size of the peak and the duration of the outbreak, thus leading to improved health outcomes for the population that's affected. Next slide, please. So now that hopefully we have a general understanding of what I've done with my modeling, I'm going to hop into some results. So these slides are specifically for when I've investigated the impact of improving response time for cholera outbreaks. And I've got two main figures here. On the left-hand side, I've got a series of proportional impacts for both cases and deaths. And what they represent is, compared to my baseline, in which we have an average response time of 105 days when an outbreak occurs, if we're able to improve that response time, say to 90 days, which is represented in red, all the way up to 15 days, which is represented in blue, for every incremental improvement to response time, we see a greater proportion of cases and deaths averted. In particular, if we're achieving a 15-day response time, we're averting up to 80% of the case and disease burden compared to that 105-day average response time, which is a really great additional impact that can be achieved with faster response. Then in the second figure on the right, we wanted to investigate what proportion of our simulations grew over certain case thresholds, which ones grew particularly large, which ones grew and remained quite small, and how did that relationship change as we changed the response time in our model. The bar on the right, which is labeled no response, is kind of a comparison for if these outbreaks occurred with no response at all. So this is saying if outbreaks were just allowed to run free, they would 40% of the time grow larger than about 500 cases. That's the area in red, and only very rarely would they stay small. So that's a lot of potential risk. But then if we look at the main body of this plot, we can see that when we're enacting a response, anywhere from 15 to 105 days, we see that the red area is shrinking. As we improve our response time, we see fewer and fewer simulations which grow above this 500 case threshold. And we can see, in particular, on the left-hand corner of this slide, of this figure, if we're achieving a 15 or a 30-day response time to these cholera outbreaks, none of the simulations grow above 500 cases, and very few of them grow above even 200 cases. So we can see that when we're responding quickly, the risk of observing large and disruptive outbreaks reduces. Next slide, please. So those figures that I showed were only for cholera, but we have equivalent representative figures for meningococcal meningitis, for measles and yellow fever from our study as well. I just don't have time to get into them. On this slide, I have a table which summarizes some of the main impacts that we found for these different diseases in our modeling study. And I want to draw attention to some key features here. So you might notice that for meningitis, for measles, and for yellow fever, in my results, I have a range of proportional impacts, whereas for cholera, it's just a single number. That's because for those three diseases, we investigated different risk settings. So these might be things like levels of vaccination coverage or the temperature factors that affect how a mosquito population grows and its biting behaviors. These things can be more or less suitable and lead to potentially higher risk for larger outbreaks. What we consistently found in our analysis was that in high-risk settings, improving response time had more impact. And so if we were to achieve 717 for each of these diseases, we could expect to see up to 80% of cholera cases averted, up to about 35% of meningococcal meningitis cases averted, up to 55% of measles cases averted, and up to 50% of yellow fever cases averted just by responding more quickly. Next slide, please. As an overall summary, and for some takeaways, we consistently found that improvements made to vaccine response time would reduce the health burden of outbreaks, and it averts the risk of observing large disruptive outbreaks. We consistently found that when these improvements were made in high-risk settings, such as those that are under-vaccinated, the impact was greater. And so where resources are limited, it might be best to focus on these high-risk areas where we expect to see larger outbreaks. And I just want to reiterate that I'm not proposing how to achieve 717. I'm just trying to motivate with further evidence, more people to invest in and do their own research, perhaps identify bottlenecks that could be relaxed so that we can work towards achieving 717 together. Next slide, please. Before I finish, I just want to thank my co-authors at the Burnet Institute, who this work would not have been possible without. Next slide, and thank you.
Dominic, thank you for that fantastic presentation. You've emphasized twice that you're not here to tell us how we're going to get there, how we're going to achieve the 717 target, but you're really showing us the potential that improvements can bring in timeliness in terms of outbreak burden and death. But I'm still going to put you on the hook, right? Cholera has been one of those outbreaks that, rather than disappearing, has actually been increasing in recent years. And one of the bigger challenges that we're seeing with cholera outbreaks has been that the oral cholera vaccines haven't been available. Your research is telling us that if we had cholera vaccines and we would use them faster, we could actually really confront and actually prevent those outbreaks from spreading out and causing more harm. I think there's some good news on the horizon, and that good news is that we're seeing more production of cholera vaccines, more stockpiling of cholera vaccines, and even approaches like preventative use of cholera vaccines are now reappearing on the horizon. Do you think that this work would really encourage countries to make resources available to roll out these vaccines during the outbreaks moving forward? What are your initial thoughts on that?
Yeah, fantastic question, Mohammed. So everything you just said lines up with my understanding of the situation as well. Things should be looking more positive for cholera moving forward in terms of the availability of oral cholera vaccines. I would say yes. Based on these results, there is great impact that can be achieved from reactive vaccination. And we've known that for a while, because as you identified, it's primarily how we've been using the cholera vaccines for at least the last few years because of supply shortages. I think there's more work to be done. Actually, an analysis that I'm working on at the moment is working directly on the question of should we use vaccines preventively or reactively in the context of outbreaks, and cholera is one of the diseases that we're looking at. So I think it's still an open question, but we know for sure that yes, reactive vaccination is effective, particularly when delivered quickly.
Thanks for that. Now, Dominic, there are people that have questions about models, right? And this is your area of expertise. Um, some models use some techniques. You use agent-based models. What makes you confident about the approach that you've used for modeling for these diseases?
That's a fantastic question. And the broad answer is that you need to design your model to be appropriate for the question. What I have found, and what the other modelers at the Burnet that I work with and at other universities have quite commonly found, is that when you're working in an outbreak context, it's randomness that can make a huge impact. If you're modeling an outbreak, it may just be that if you seed an infection in one place, in one person, it may go nowhere just randomly because they don't interact with anyone. Otherwise, if you seed that infection in another person in the model, they may interact with and infect 10 people, and suddenly the outbreak is exploding. What agent-based models can capture is that randomness, and it does so mechanistically because they can model specifically networks and the way that people interact with each other in things like households or schools or workplaces. And it just adds, at least for outbreaks, just a little bit more reality to that randomness. And we found that that works well in the context of outbreaks.
There's a question in the Q&A that says vaccines are usually delayed during outbreaks. How did you? Oh, I think that's been answered. Oh, it's another question. It says, Dominic, your model considering the impact of, does it focus on ring vaccination or larger campaigns at outbreak site or a mix? What approach did you use?
Yeah, very good question as well. So for these diseases, we basically just modeled large scale mass vaccination, which is randomly targeted. I've done previous work which investigated ring-based vaccination in the context of Ebola, and in that context found that ring-based vaccination with effective contact tracing is better than random mass vaccination. But in this study, we just looked at random allocation in the target populations.
So Dominic, some of our audience members want to know where secondary impacts like healthcare burden or economic costs modeled in your paper.
Yeah, another fantastic question. In this paper, no, we didn't address that. We purely looked at cases and deaths averted with some translation into disability adjusted life years. We didn't do any economic modeling or secondary analysis. I think that's a valuable thing to know, and so it's worth looking at more closely. And it's something that I have done in the past, just not with this study.
Sooyoung, this is a question for you. We've talked about timeliness and outbreak outcomes, and a question has come in as, what other factors did you consider in your study?
Yeah, I think that's a really great question. And sadly for our study, due to the limited contextual data that we had in our hand and a small sample size, we didn't want to overcomplicate our study by adding multiple confounding factor into our regression. So we really thought the disease category, the types of disease that caused the outbreak was one of the most important factors. And we happened to have that information available and we accounted for that. But I think future studies that will improve on the methodology should definitely consider other critical contextual factors. And hopefully we'll get to see those studies in the future.
Thank you. And Dominic, there's another question. It says, how closely did the baseline scenario of about 30 days to outbreak response immunization match observed historical delays for the 4 diseases in LMICs? And what data sources informed the faster response increments or the 15-day time frame?
Yeah, no, great question. So each of our baselines for the 4 diseases were based just on the average response time. So in a previous piece of work that we did with Gavi, the Vaccine Alliance, we gathered a data set of 210 outbreaks of vaccine preventable diseases in low and middle income countries. And each of these outbreaks had their own responses. So we had, this data set of over 200 outbreaks and we knew, how many vaccines were delivered, how long the delay was between outbreak detection and the response start. So we just took the average across those four diseases to inform our baseline, and it typically tended to be around 3 to 4 months. And so that's what we implemented in the model. In terms of those incremental improvements in our scenarios, there was no data to inform that. They're purely hypothetical scenarios, just set in these 15-day increments to try and see what regular improvement to response time could achieve, so that we could have measured steps and say, if you're hitting 60 days, it's this amount. If you're hitting 30 days, it's this amount. But they weren't informed by data, just hypothetical.
And really, I think that's the big takeaway really from your work is that, if you just have even incremental improvements, you
Yes.
start to see benefits, and all incremental improvements potentially can lead to lives being saved. It's really stunning paper, and congratulations on that. I also want to thank Kim for a really outstanding pioneering paper. Both of our presenters have made time for us to present their work and to discuss with us. Please go ahead and read the full paper. And if you have any other questions, you can send them through to the Alliance, and we'll also help to elevate those as well. But thank you very much for your presentations and for participating in our Q&A. Really, really interesting webinar so far. What strikes me is that you have the evidence that demonstrates that you can save lives. And timeliness can really be that approach that we use to save lives. But it's not going to happen by reading the data or by reporting. It's really going to happen if we bring about change in practice. And so our next section is really we're going to hear from practitioners in the field. And we're really thrilled to have with us Peter Elianu. He's the Director of Global Health Security at the Baylor College of Medicine's Children's Foundation in Uganda. And we've seen some of the data from Uganda. We now have an opportunity to see Peter's experience supporting implementation of 717 at some national and national level in Uganda. Peter, welcome to our webinar. I'd like to ask you a couple of questions to follow up on this discussion. So we've seen the evidence saves lives. We really want to know, what's your experience really supporting implementation of 717 in Uganda?
Thank you. Thank you very much, Mohammed, and thanks for inviting me to this webinar. So Mohammed has mentioned I work with Baylor Foundation Uganda, and most of our work revolves around preventing, detecting, and responding outbreaks, and we support the Ministry of Health. So for us, the experience with 717, I think we're lucky that Uganda was one of the countries that that piloted the 717. And the ministry, of course, working with Resolve to Save Lives and Infectious Diseases Institute, shared the findings from the pilot that was done at the country. And I want to say that it landed at the right point when we were looking for how best to quantify the outcomes of our work. We're doing prevention, detection, response, and training, and we're asking ourselves, how do we know if we are actually making progress with this work? And how best do we present these outcomes? And 717 seemed to give us that one tool that we can use. And we started internally to get internal buy-in. Sometimes you can have something nice, but even within your institution, you don't get that buy-in. So I had to have buy-in within my team first, and I worked with the Ministry of Health, Resolve to Save Life team, and IGI, and I made sure there were presentations done to my team and in Baylor, but also strategically made sure that I got these presentations to get to the donor, because I knew eventually I will need some money to roll out these. So got presentations to CDC, USAID at that point. And once we got some buy-in from the donor, and I will talk a little bit about advocating on the donor side later, we had to do work plans and make sure that we put in some money to support the early action reviews. But within the institution, we also created the highest level of accountability for that work. And we made sure that there were indicators about the rollout of the 717 and performance of the districts that we had to present to the board at the institution level, because we found it was an easier thing to talk to the board about, and the donors, and of course the Ministry of Health. At rollout, we took a bit of a different approach. We said we will train districts as they get outbreaks. So we didn't go to the portion of training everyone without an outbreak, and we found that very effective because it then made the training on the 717 very, very real. Because when we would detect an outbreak, then we'd sit with the district, would review the timelines, look at the bottlenecks, and as well as look at the enablers and support them to address the bottlenecks. And we made sure that as we're presenting these results, we included the political leadership at the district for buy-in. Now, for the political leaders, you really have to use strategic language. You tell them, if we are doing early action reviews, this is going to help us, number one, to reduce the number of people who get sick. You will save the lives of your people and you'll save money. So when you talk about saving lives and saving money, everyone gets interested. At district level, you'd have a bit of fears. People at one point thought, oh, is this a tool that is going to be used to punish our performance? So we also had to present it to them differently and say, for you, this is a tool for monitoring and evaluation for quality improvement. It's not so much what you get at the beginning, but we want to see improvements in this, and potentially it's also an advocacy tool for you. If you see the gaps, you can use those gaps to advocate for more support and more resources at district level. So we did that systematically across different districts that we had that we're supporting. We're supporting at that point close to 25 districts. And interestingly, what we started seeing, we looked at our data and we decided to look at districts that had at least 2 outbreaks within 1 year. And we found that there was improvements, like the median time to detection over about 20 outbreaks that they had seen reduced from about 8 days to 5 days. And also the response time reduced from about 15 to 7 days, almost half, by those districts implementing the early action reviews and measuring using the 717 metrics. So it was very critical. The events that finally were meeting all the targets increased from 0 to about 46%. So it was a powerful tool for us. And I think for me, the biggest lesson is that the biggest advocacy lesson is you need to understand the stakeholders that you're going to and design a message that tells them what is in it for them. When you go to the politician, what is in it for the politician in these early action reviews and 717? They are concerned about the lives of their people, few people falling sick, lives saved, money saved, business, less disruption in business. And I think for me, one of the really game changers was when I attended the conference in Sydney, in Australia, and there was a gentleman from Resolve to Save Life who presented that graph and showed that, with early action reviews, then the size of the outbreak reduces. And that is a tool that we used, and we said, when you do this, when you act early, identify the bottlenecks, this is what your curve will look like. You'll have fewer people. Advocating to the donor, I think you have to learn to know what to use. So part of what we're telling our donors is, you've been giving us money to strengthen prevention, detection, and response to outbreaks. This tool now helps us to show you that where you're putting money, things are actually working. and working consistently, are there improvements? Because ultimately, all the work that you do in preparedness and so on is tested by outbreaks. It's at that point that you realize that you're actually prepared.
Wow.
Districts, performance improvement tool, and an advocacy tool, and they will embrace it. Thank you.
Peter, that's an outstanding submission. I'll say congratulations.
Thank
You
you.
know, your work in support of the districts, moving from 0 outbreaks, meeting the target, to over 40% of outbreaks meeting the target in such a short time is tremendous. Congratulations. And thank you for also sharing those insights. We have to think about organizations, we have to think about governments that we support. We also have to think about funders and donors. Thank you very much for your submission today, and we're really thrilled you could make time to participate in this webinar with us.
Thank you for having me.
Yes, thank you so much to all of our speakers who have joined us today to share their work. And so far today, we've heard from two phenomenal researchers presenting clear evidence that when it comes to outbreak detection and response, that speed saves lives. The evidence shows it. But we also know that translating evidence to practice can be a complex and lengthy process, as Peter just shared with his own experience. And it can take a lot of time and trust to make meaningful changes in these complex systems. And so how do you get started, right? Often you get started with a conversation. And so you may find yourselves in planning meetings or management conferences, or even just interpersonal conversations and situations where you have the perfect opportunity to advocate for adoption, use, or advancement of 717 in your setting. You may already be doing 717, but find that getting real buy-in to address the bottlenecks surfaced with 717 is tougher or taking longer than anticipated. And so we're going to take the last segment of today's session to go through some concerns that you might hear and give you some examples as to how you can respond in a way that meets resistance with evidence for constructive progress towards our goals. And so for this segment, I'll ask Mohammed to join me and help us craft some clear and compelling responses to common concerns that you might come up against in real life. Okay? So, Mohammed, first, how do we know that 717 actually works? It would require a lot of effort to get started. Can we be certain that it's worth it? Oh, Mohammed, you're muted. Can you start again?
Right. So it's really important to be able to show that evidence, right? How do we know it works? A growing body of peer-reviewed research, country experience now demonstrates measurable impact. We want to provide that type of leading in that conversation. And the studies that have been presented today are really the tools you can use to really advocate specifically on outbreak and timeliness. So please use the information that's been presented today. Encourage people by making it very clear that this is not just your opinion on the issue, but there is published evidence that supports the assertion that 717 works.
Okay. I know that there's research and that's great, but what's the actual benefit of 717? What's in it for me?
And I think this one is easier, right? We've said it, speed saves lives, right? So keep that at the back of your mind and feel free to use phrases like that. Speed saves lives. Faster detection and response reduces transmission, reduces deaths, and it also reduces the economic costs. And these are quantifiable, not just theoretical assertions. So make it very clear that this is about saving lives, it's about reducing outbreak size, it's about reducing outbreak duration, which in turn reduces the economic impact of outbreaks.
Okay, all right, that makes sense. But I'm concerned that we just don't have the resources for new initiatives like this. We are stretched so thin already.
And this is a real challenge. And I think we have to acknowledge that these are real challenges that people face. But 717 can also help, even where resources are delayed or misallocated or blocked by policy and administrative bottlenecks. 717 can be used to help you prioritize what exactly needs to be addressed first, and then have improved outbreak performance subsequently. So you can position 717 not as a resource consumer, but as something that helps you to prioritize and plan and improve the efficiency of your system. So reposition in the discussion and framing 717 as a tool to optimize planning, support prioritization, and use what limited resources are present more effectively.
Interesting. I see. But at the end of the day, we have plenty of frameworks to choose from and plenty of reporting tools that we're using already. Isn't 717 just another framework?
I think here you would say that, 717 is a new framework, agreed. It does provide timelines that can diagnose systems failures and inform improvements with precision, right? It enhances and doesn't replace other existing frameworks. But I think it's also important to mention that 717 as a framework has already been widely accepted by global players. It's part of the WHO's General Program of Work. The World Bank has incorporated it in its results framework. The Global Fund has incorporated in results framework. The Pandemic Fund has incorporated in its results framework. And essentially, we have broad consensus among global stakeholders on the use of 717, and we can line up behind that and move it forward.
Right. Okay. All right. You've convinced me. That's really compelling. But how do I get started? What's the first step to making change?
So you have to start where you are, right? And we generally recommend that you start small. One outbreak review is enough. You take one outbreak, you review the performance, you look at the bottlenecks, the enablers, and you already have a message about your timeliness and your challenges and opportunities. And that's enough to start to build momentum. Now, if you're able to build momentum and get a win from that first outbreak, you have the confidence to try and expand and do more. And so for those people listening on the call, start where you are, identify your entry points, and then use that as an opportunity to move and build and do more. We have a community of practice, people who have already started using the 717 target in their setting. And this exact thing, how do we get started, is one of those elements that they learn from, they share with each other. And if you're part of our community of practice, you'll also have that opportunity to get that information. Now, all resources from the 717 Alliance are available free of charge. They are global public goods. Please go to our website, download tools, training materials, any resources you need. And we always say the 717 Alliance is here to help. You can reach out to us with specific questions for support. Thanks.
Wonderful. Thank you so much, Mohammed, and thank you to our speakers. So, Mohammed, any final remarks to close us out for today?
I mean, it's really been a fantastic session today, and I'm really grateful that our speakers made the time to prepare and present to us, and a really wonderful experience that we've seen also from our colleague from Uganda. Speed saves lives. Let's remember that. And once we know that and have that at the back of our mind, we know we can't sit on that information. We must do something. Let's make a commitment today to make an improvement in our system and help to detect outbreaks faster, notify faster, and respond faster. Thank you very much.
Wonderful. Thank you. So, everyone, as we conclude our session today, we hope you've seen how research can and should compel advocacy, action, and accountability. and you can use 717 to do that. So as we prepare to sign off today, we would love to hear from you. Feel free to add your thoughts in the chat about these two questions that you see on the screen. What is one data point you've learned from today that compels you to act, that compels you to do something that you weren't doing before? And maybe what's one specific advocacy point you think you can make in the next 30 days to advance 717 in your setting? To whom will you make this point and about what? Okay. And so as we close out, and you can flood the chat with your commitments for the next 30 days, we want to highlight several exciting updates from the 717 Alliance. We have several new publications hot off the press, including several new operational research papers from Cambodia, South Sudan, Thailand, Uganda, and Zambia. And all of those links are available on our website. We can also share some of them in the chat. We are planning to host a two-part financing series in our global community of practice in the next couple months. So that's for COP members only. We know this is a hot topic, so we really hope you can join us. We'll be sending information about that soon. And please feel free to join us in the community of practice if you haven't already. And lastly, we are getting ready to hit the road in the next few months. If you are planning to attend the World Health Assembly, join us for the launch of Epidemics That Didn't Happen. And you will also see us at the Global Health Security Conference in Kuala Lumpur in June. We hope to see you there. Feel free to stop by, check out what we're doing, and tell us what you're up to. Thank you again, everyone, for your attention today and your commitment to advancing 717 in your setting. And take care. Bye-bye.